Professor Jeroen, are you online?
Yes, I am, but I cannot share the screen because somebody needs to disable it.
Thank you very much. I'm really grateful to you for taking time out. I know how busy you are. And I'll give a brief introduction about you and your past achievements. Professor Bax has served served the ESC in numerous capacities, including Chair of Cardiology Practice Guidelines Committee, Chair of the Scientific Committee, Chair of the Press Committee, and co-chair of 2 international conferences on nuclear cardiology, and co-editor of 2 ESC books on cardiac imaging. He is the Professor of Cardiology and Director of Cardiac Imaging at Leiden University, Netherlands. Professor Bax, the floor is yours for multimodality imaging in heart failure. Thank you.
Thanks very much. I need to host disabled participant screen sharing. So somebody needs to open that I can share the screen. Okay. I trust you see it as well.
Yes, we can see your slides now. And listen.
Okay, thank you very much. So you asked me to talk about imaging in heart failure, so it's a pleasure to do that for you. I keep it very simple. This is the way we approach it in our center. So severe heart failure patients, it's all about the therapy. And so it's medical, but you also need to think about revascularization. You need to think about, should I treat valvular heart disease? So it's not just medical, but it's also thinking about interventional procedures. So we're going to talk quickly about LV function, LV size. That's what you want to know. How big is this ventricle? How bad is the function? We're going to talk about what is the cause of the heart failure. Is it coronary disease? If so, do I need to revascularize? If not, is there severe mitral regurgitation? Do I need to repair that? These are the 3 main markers that you have in mind. Also here you could think there could be a 4th, do we need an ICD? But we give all these patients an ICD and CRT if it is needed or indicated. If we talk about ejection fraction as LV function, we know that once ejection fraction goes down in the 20s, your mortality goes up steeply. This has been proven already in 1986, and over the years, many articles have addressed it, and each time they come to the same conclusion. Once you go below 30-35% in ejection fraction, you actually increase your mortality significantly. LV function, LV size is pretty easy. We do an echocardiogram. Here you see a very bad heart. Here you see the 2-chamber view. There is the 4-chamber view. It's clear that this patient has a huge infarction in that area. Also, this part here is akinetic. Here you see a big apex that's not functioning well. If you see a big heart like this, your question is immediately, does the patient have maybe LV thrombi? Most likely they have LV thrombi because this is all scar here and is not moving. But what you want to know is there's some thrombus where I need to think of some procedure, because if it's really moving in the left ventricle, you need to think about some treatment. For better understanding what is going on in the ventricle, if there is thrombi, etc., we give intravenous contrast. This is a different patient, but it's just to illustrate you that with the contrast, we see so much better these contours that we can pick up immediately when there is a thrombus in this area. Here you see an example of that. This is another patient. Here is the left ventricular thrombus, very clearly to pick up when you do the contrast. This is commercial available contrast. This is not just bubbles. Bubbles we use just for looking at shunts between the left and the right side. But if you want to have better LV border opacification, then you use these commercialized contrasts. We start to move away with echocardiography more and more from 2D imaging to reconstructed 3D imaging. And now most of the systems have all introduced that, and we see very, very well the LV function. And when you add here also the contrast, you get an even better picture. And it's very easy to quantify with these 3D approaches the LV ejection fraction. We have moved on now to artificial intelligence in our department, where this is all done by the modern machines automatically for you. You don't have to measure anything anymore, the machine gives it. I like in most of these patients with severe heart failure to have an MRI. Why? Because you see so much better exactly what's going on in this ventricle and what's going on in this atrium and what's happening with the valve. Here you see a normal patient where it's very clear that right ventricle, left atrium, you can see the pulmonary vein inflow happening here. And this is the right atrium. If we look at the short axis, we see exactly how that right ventricle is wrapped around the left ventricle, and you see the trabecularizations on this side. We also see the wall of the left ventricle. We see the papillary muscles. So it's very, very easy to assess all the different parameters with an MRI. We cannot do an MRI in every patient, but if we could, we would certainly like that better than an echo. But again, with echo, we move mostly from 2D to 3D in complex cases. We also have CT scans. Here's a CT scan, and we use that mostly for coronary arteries. But you see here a very bad ventricle, very easy to pick up, relatively thin wall, posterior, lateral, and anterior. All these numbers show a minus. Forget about this minus, just remember one number, and that is about 20%. A normal ventricle global strain has 20% global strain. That corresponds with an ejection fraction of 50-60%. Here you see the different severities. This is a normal ventricle, 19%, 20%. This is an acute infarction in the inferior wall, 13%. And this is severe heart failure with only 7% of global strain left. You can see that every part of it is now sort of pink or blue. That means that all these parts are not functioning anymore. The strain imaging comes like this. We can do it in the longitudinal. We can do it in the circumferential and the radial. That gives us very complete information, but in the daily practice is what I just showed you. We use this polar plots. It's very useful when ejection fraction is normal and still something is going on with that heart. Here you see the patient with chemotherapy. It looks all fine, has an ejection fraction of 60%, but this area here is already showing fibrosis with significant reduction in this posterior lateral wall, where the strain is only 10%, whereas it should be 20%. 21-year age man, anthracycline for lymphatic leukemia, ejection fraction perfect, global strain already starting to reduce, and you can pick up completely where the area is. Another one for you is aortic stenosis, very thick septum, a little bit enlarged left atrium, very thickened posterior wall, also posterior inferior, and you see the valve that's heavily calcified and is not opening. Here you see the gradient. It has an aortic valve area of 0.9 centimeters square with a mean gradient of 56. Ejection fraction 62%, but my global strain is already significantly reduced and is 13% only in the septal area where the thickening is taking place, where the fibrosis replaces the normal myocytes. And as a result, strain goes down. So the global strain of this heart is 13%, but these parts are relatively normal, but this part here is totally abnormal, and that is the thickened fibrotic septal area. So in the severe heart failure patients, we spoke about LV function, LV size. Then you want to know, does the patient have coronary disease? And if so, does he have ischemia and or viability? We do an angiogram in all these patients, same like you. Here you see the patient with severe triple vessel disease. But we can also do in these patients now CT scans. And we do it not so infrequently. We do it more and more in these heart failure patients because they have nowadays very good control with the heart rates, and the CT scanners can move so fast so that we get a non-invasive picture immediately, and we see the coronary arteries where there is some calcium, little bit of stenosis here, but at least we know immediately, are these coronary arteries normal or not? And if so, if they are abnormal, then we can consider doing an angiogram. But in the non-ischemic dilated cardiomyopathies, it's good to see immediately coronary arteries normal. We don't need to do anything else invasively. The CT scan is super good for ruling out. If there is no stenosis, if there is no atherosclerosis, that means you have no coronary artery disease. Assessing coronary artery disease, the next step is that you look for ischemia. If there is atherosclerosis, if there is a stenosis, you can do an invasive FFR. You can also do it non-invasively with a traditional nuclear scan where you see the stress pictures here, short axis and the long axis. There is a defect here after stress, there is a defect there after stress, and there's a defect here. When I scan in the resting situation, all perfusion is normal in this heart. So this area of about 30% of the ventricle has ischemia. And that gives you the next step. So should I revascularize if you have severe ischemia? Yes. Then comes the question, is there viability? And if there is viability, should we then revascularize? Probably yes, because we know that if your patient has viable but dysfunctional myocardium and you revascularize them, the event rate is low. Whereas if I leave them on medical therapy, quite often they will have an event in about 20% of the patients. Viability you can do in many ways. You can do a stress echo, you can do an MRI, you can do delayed enhancement. I'll show you that in a second. But we do in a lot of these patients still a nuclear scan because sensitivity is pretty high. So this is the perfusion scan. There is a huge perfusion defect here and a perfusion defect there. And if I look at my metabolism, you see that here, that there is metabolism in this wall, whereas it's gone completely in that wall. That means that this is so severely hypoperfused, but still alive, that you need to consider revascularization. You see that also, for example, very clearly in this part here. There is basically no perfusion, but there is significant glucose uptake. That means that this is an area of hibernation and you should revascularize. We can also do pure scar imaging. Here you see a patient with a non-transmural in the white, non-transmural lateral infarct. And this is a big infarction in the anteroseptal region. With this technique, basically, we see immediately where the scar is, but we do not know about the rest of this part here, if it's viable and jeopardized, or if it's just viable and non-jeopardized. With that, I mean, is this perfused by a stenotic one or a non-stenotic artery? The last part that we look at is severe mitral regurgitation. Here you see the very simple pictures. We go back to our patients. This is his transthoracic echo. This is his transesophageal echo. You see the very bad ventricle that we discussed before. You see that there is tenting of that mitral valve. There's retraction into the ventricle. There's this big akinetic area of scar tissue. And you see that the patient has a central mitral regurgitation. We see that even better on the transesophageal echocardiogram. Functions very, very bad. And you have a central, slightly eccentric in the atrium of mitral regurgitation. But for sure, this is significant mitral regurgitation. And we know that if you have moderate to severe MR, that your outcomes is significantly worse than if you have no or just a very little bit mitral regurgitation. So another point is look for ischemia, look for viability, and then look for mitral regurgitation. Because if you first do a revascularization surgical procedure and you have to go back the next month for a mitral regurgitation, that would not be great. We have developed over the years these MRI techniques where we can measure both the mitral and the tricuspid valve, basically also the aortic valve if we want to. As you see here, we can place the scouts over all the different valves. And for each valve, we can measure the flow over that valve. And so if we take out, in this case, the mitral valve, we can measure the forward volume and the backwards. And based on that, you can calculate the precise regurgitant fraction. And that gives you a good indication how less or how severe this mitral regurgitation is. This is the summary that you asked me to give, like what do we do in diagnostics with a patient with severe heart failure? So number one is, what is the etiology? Ischemia, what is the etiology? Is it coronary artery disease or not? If it is not coronary artery disease, you come to the rare diseases and you look for what is causing this LV dysfunction, what disease is underlying. Most of the patients, I would say 80% plus in our clinics, have ischemic cardiomyopathy. The second step is always an invasive angiogram to look what is the lesions in the coronary arteries. Then we add some things, which is an echocardiogram, looking for the function again, but also looking at mitral regurgitation and sometimes tricuspid regurgitation in the heart failure patient. Should we, if we revascularize that patient, do something about the mitral valve and or tricuspid valve? Then there is imaging for ischemia and viability. I've shown you that. That gives you an indication, should I revascularize? If there's ischemia, certainly yes. If there is no viability, you could consider maybe not to revascularize that area. But it gives you a comprehensive assessment of the patient. It's not too difficult. You use echo, echo, and echo. And then you have some advanced imaging. If you have it, you can do an ischemia test with nuclear, but you can also replace that for a dobutamine stress echo. You can do an MRI for picking up the scar, but now with the strain, if the strain is very low, we know that there is scar, so we can also replace that with echocardiography. And for the valve disease, echocardiography is the number one. So although it is multimodality imaging, we do in a lot of patients just very extensive echocardiography and then add, when we feel that we need it, some form of advanced imaging. Thank you very much.